Bismillahirrahmanirrahim. I am Dr. Asim. In the last lecture, we discussed about the basic metabolic effects of the thyroid hormones and their production and their biosynthesis. In this lecture, we will be discussing about the thyroid function tests, Graves' disease, and how it is diagnosed. Then hyperthyroidism and hypothyroidism causes and the etiology, and most importantly, the lab diagnosis of hyper and hypothyroidism. At the end of this lecture, we'll be having two MCQ, which you'll have to answer with your roll number, and then your attendance will be marked for this one. Thyroid function tests, they are categorized on different varieties. For example, the measurement of thyroid hormone, the circulating levels of thyroid hormones like T3, T4, FT4, FT3. These are the circulating hormones in the blood, which we can measure and assess the status of the patient. Then test of the thyroid pituitary axis, the basal serum TSH level, thyroid stimulating hormone level, which is the most important in this thyroid function test, which we have to measure along with these two hormones to differentiate different conditions like hyperthyroidism or hypothyroidism. Later on, we'll discuss which of these hormones is most important to discuss. Then there is another test which is not commonly used, but if the cause is not established, then serum TSH response to exogenous thyrotropin releasing hormone is assessed by the response of the TSH level. So measurement of the thyroid hormones and test of the thyroid pituitary axis. These are the two categories in which the thyroid functions are based. Then test for the autoimmune thyroid diseases, because as it is very evident, it was evident in the last lecture also, the autoimmune etiology is also for the different thyroid disorders. Anti-thyroglobulin antibody, anti-thyroid peroxidase antibody, it is TPO, anti-TPO commonly called, anti-microsomal antibodies, and then TSH receptor antibodies. These are all different bodies, but all are not performed. But depending on the cause, we have to go for the differentiation of the autoimmune etiology of the thyroid disorder. Then there is role of fine needle aspiration cytology. In this, if there is a swelling or nodule, we can differentiate either it is benign or it is malignant. This is one of the tests which is used for the swelling in the neck in the thyroid area. Then thyroid scan, which is used for the differentiation of the thyroiditis in which the uptake is decreased, and other Graves' disease and adenoma in which the uptake is increased. These are briefly the thyroid function tests. Now, hyperthyroidism, strictly speaking, is only one most common cause of thyrotoxicosis. The terms primary and secondary hyperthyroidism are sometimes used to designate hyperthyroidism arising from the intrinsic thyroid abnormality, and that arising from the processes outside the thyroid, such as TSH secreting tumor. These are the two different conditions in which we have to differentiate either it is primary or the secondary. So hyperthyroidism refers to the excess synthesis and secretion of thyroid hormones by the thyroid gland, which results in accelerated metabolism in peripheral tissues. It is important, the symptoms of, to remember the symptoms, how the patient presents, this must be kept in mind. The three most common causes of thyrotoxicosis. Now, this thyrotoxicosis or thyrotoxicosis with hyperthyroidism or thyrotoxicosis without hyperthyroidism are two different terminologies. You must be able to differentiate between the two. thyrotoxicosis with hyperthyroidism, and thyrotoxicosis without hyperthyroidism. The three most common causes of thyrotoxicosis are also associated with hyperfunctioning of the thyroid gland and include the following: diffuse toxic hyperplasia, which is the Graves' disease, diffuse hyperplasia of the thyroid associated with Graves' disease. Secondly, hyperfunctioning multinodular goiter, which is another common condition which you have to differentiate from this one. And then hyperfunctioning toxic adenoma of the thyroid. Then there may be the secondary causes like pituitary adenoma, which is secreting too much TSH and leading to the hyperthyroidism for the production of the by the production of T3, T4. The term thyrotoxicosis without hyperthyroidism, in these conditions, there may not be the symptoms of the hyperthyroidism, or if they develop, they may be mild and may not present the true picture of the hyperthyroidism, like Hashimoto's thyroiditis, granulomatous thyroiditis, and postpartum thyroiditis. Then there may be some silent type of the thyroiditis. These are the conditions in which there is thyrotoxicosis but without hyperthyroidism, and symptoms may be very mild, which may not be diagnostic for the hyperthyroidism. Then there is another term which is apathetic hyperthyroidism. It refers to the thyrotoxicosis occurring in the elderly with advanced age, having comorbidities like diabetes, like blood pressure, and like cardiomegalies or other things. They blunt the picture of excess thyroid hormone level. So, for assessment of the symptoms which may not be present, then these patients' thyroid function tests are advised. Laboratory workup is required for these, in which there may be only weight loss, or there is worsening of the cardiovascular disease in the elderly patient. For that, we have to differentiate the other causes of these two conditions. Graves' disease is an autoimmune disease that leads to the generalized overactivity of the thyroid gland. It is the most common cause of hyperthyroidism, and it was named after Robert Graves 150 years ago, about who was an Irish scientist. It occurs most commonly between the ages of 20 and 40 years. Women are more affected, 10 times more than men. It is most runs in the family also, and it is common in those persons who are having HLA-B8 and DR3. These are the some brief outline of the Graves' disease. Basically, it is a triad of three things. That is thyrotoxicosis caused by the enlarged gland. Second is the infiltrative ophthalmopathy. And third one is the infiltrative dermopathy. Too little production of the hormones that leads to the hypothyroidism. Thyroid gland is prone to several very distinct problems, some of which are very common. They are concerned with the overproduction of the thyroid hormones. So in this case, we have to differentiate between the levels if the symptoms are not very much clear. But in Graves' disease, these three conditions, these three states, enlarged thyroid gland and ophthalmopathy and dermopathy, this is clear evidence of the Graves' disease. Basically, this is a hypermetabolic state, which is due to the excessive secretion of the T3, T4, free T3, free T4, hypermetabolic state, heat intolerance, weight loss, tachycardia, palpitations, tremors, hyperactivity, emotional lability. These all we discussed in the last lecture that these may be the changes in which uh, any condition, as we are studying the Graves' disease, any symptom may be present or multiple symptoms out of these may be present. Now see, if you look at this, there is enlargement of something, looks like swelling over here. What it can be, it has to be differentiated by the palpation, if it is the thyroid, if it is having some particular nodule on one side or the other side, we have to go for the differentiation of some adenoma or some other disorder. But in Graves' disease, it may present like this. Now, this is clear evidence of these bulging eyes and accumulation of this fluid around the eyes. It is a toxic look and it is a typical feature of the Graves' disease. If you see from the side, there is bulging of the eyes. From here, you can measure the angle over here, and it is the clear picture of typical feature of Graves' disease. Then there is flushing skin, smooth skin, which is the infiltrative dermopathy, which is a feature of the Graves' disease. Clinical presentation. Younger patients tend to exhibit symptoms of sympathetic activation like anxiety, hyperactivity, tremor. You will see patients having some tremor and they cannot you put the paper on the back side of them to assess the tremor. You can easily differentiate the patient is having. Patient may be hyperactive, he may be anxious. These are the some signs or symptoms in younger patients. In older patients, they have more towards the cardiovascular symptoms like dyspnea, atrial fibrillation, and unexplained weight loss. So keeping in mind, we have to go for the thyroid function test in all type of these symptoms if the patient presents any of the symptom. Then patient with the Graves' disease often have more marked symptoms than patient with thyrotoxicosis from other causes. This is point to be noted. Those patients who are clearly having Graves' disease, they will have more marked symptoms as compared to the other cases like autoimmune disorders, granulomatous or Hashimoto's. They may not be having the more pronounced symptoms or signs as compared to the Graves' disease. Ophthalmopathy, periorbital edema, diplopia, or proptosis, these are the clear indications of the Graves' disease. What is the pathogenesis? Very simple one. It is an autoimmune disease which results due to the breakdown in the helper T cell tolerance and their body's own cell. They produce some receptors, antibodies are attached to that one. So there is a hindrance to the function of the TSH to the thyroid cells. Now, anti-TSH antibody production is one of the symptoms of the Graves' disease, which are called TRAB, thyrotropin receptor antibodies. Instead of attaching the TSH to the thyroid gland, they act on the receptors and produce the production of the thyroid hormones. Then infiltration of the retroorbital space by mononuclear cells, as you saw in the picture. There is edema of the extraocular muscles, so it looks like a bulging of the eyes. Then there is deposition of the hyaluronic acid and chondroitin sulfate accumulation around the eye, and there is increased number of the adipocytes in the ophthalmopathy. The thyroid stimulating immunoglobulins, they bind to the TSH receptor and mimics the action of TSH stimulating adenyl cyclase with resulting in increased release of the thyroid hormone. It means TSH receptor is occupied by the antibodies which are produced by the body's own cells, and they act like the TSH and stimulate adenyl cyclase, and which resultant increase in the thyroid hormone levels. Almost all patients with the Graves' disease have detectable levels of the TRAB, which are TSH receptor antibodies. Thyroid stimulating immunoglobulin, this is different from this one, is relatively specific for the Graves' disease in contrast to the thyroglobulin and thyroid peroxidase antibodies. Another because it is an autoimmune disorder, so different types of the antibodies are produced. One is TSI, second is the TGI, and third one is the TSH binding inhibitor immunoglobulins. These two are very important for the differentiation of the Graves' disease from the other autoimmune disorders of the thyroid gland. Morphologically, there will be the changes in the thyroid gland, diffusely enlarged thyroid gland. There will be hyperplasia, hypertrophy of the cells, and capsule will be intact. The follicular cells will be tall, columnar, and more crowded. There will be infiltrate of the lymphocytes, mainly the T cells and plasma cells. With treatment, there is involution of the epithelium and accumulation of the colloid. This you will see in the next picture. There is fibrosis development with continued treatment. Now this is the normal, and this is the Graves' disease patient. These are the infoldings which are present over here. How we can evaluate hyperthyroidism? What test we can go for? First of all, if there is suspicion of the thyroid disorder, just go for the TSH levels. If it is normal, then patient is euthyroid. Euthyroid means no thyroid abnormality, thyroid functioning is normal. If it is low, then you must suspect hyperthyroidism, whatever the cause. Presently, we are discussing hyperthyroidism and hypothyroidism. If TSH is low, patient will be having hyperthyroidism. Then we'll have to measure FT3 or FT4, and if they are high, then hyperthyroidism is confirmed. In contrast, if TSH is high, then it is hypothyroidism. Then we'll have to measure FT4 and T4. If they are low, then hypothyroidism is confirmed. Now, one thing keep in mind, here we are measuring, ideally we should, not ideally, normally it is measured TSH, T3 and T4. In combination they are measured. But ideally we should go in case of the hyperthyroid for the FT3, because there is one term which is called T3 thyrotoxicosis. If it is present, if we measure T4 over here, and if that is normal, then we get confused. But if T3 is raised, it means that term is also included in that evaluation. In hypothyroidism, we can go for the FT4 or T4 for evaluation. So it means, first of all, TSH, then if it is low, then you think hyperthyroid. If it is high, then hypothyroid. This you must not confuse in the exam. Now approach to the patient with clinical suspicion and hyperthyroidism only. TSH level will be low, free T3, then T3 elevated, hyperthyroidism, then we'll go for the radioactive iodine uptake scan. Uptake scan, if it is Graves' disease, the scan uptake will be more in toxic adenoma also and in multinodular goiter. And it will be decreased in thyroiditis like granulomatous or other inflammatory or autoimmune diseases of the thyroid gland. The importance of the autoantibody titers is very significant in the sense Graves' disease significantly elevated anti-TPO and elevated thyroid-stimulating immunoglobulin. You have to remember this one. Toxic multinodular goiter, low or absent anti-TPO. This differentiates between the two. Toxic adenoma, low or absent anti-TPO. Now, if there is suspicion that the levels are equivocal, they are not significantly clear enough to differentiate between the two, then we have to go for this one, these autoantibodies. Patients without active thyroid disease may have mildly positive anti-TPO. Now, this is the typical thyroid hormone levels in thyroid diseases. Just keep in mind, this is TSH, T4, T3. In hyperthyroidism, TSH will be low, T3, T4 will be high. In hypothyroidism, TSH will be high and both hormones will be low. If you keep the picture in mind of a pituitary and the thyroid, the action of the TSH on the thyroid gland and production of the T3 and negative feedback, then you can well imagine what picture will be in different conditions. Now, this is the case scenario. A 29 years old woman was seen in the thyroid clinic because of the exophthalmos and a goiter. She had the following thyroid function test results. TSH is less than 0.5 milli international units per liter. Normal is 0.2 to 5, but it is less than 0.5. Free thyroxine 68.8. Picomole, it is 12 to 25. It means it is increased. Free triiodothyronine, free T3, it is 18.7 and normal range is 3 to 7. What is the most probable diagnosis? Which other test can we use for supporting your diagnosis? Now, you have to answer, but it's a very clear-cut case of what? Hyperthyroidism, and cause may be symptoms they have given in it. You have to pick those one. That is the exophthalmos and the goiter swelling. And which other test should be done for confirmation of your diagnosis? In this case, it is 0.01. Again, simple case. T3 is increased, T4 is increased, and TSH is decreased. Now, you have to answer what is this one? What should be the answer over here? Okay, you have to give the answer along with your roll number. In the end, I am discussing second scenario. A 22 years old woman has experienced increasing fatigue and a 7 kg weight loss without dieting over past 4 months. She has also experienced increasing anxiety and nervousness with no apparent changes in her job or home life. There are two symptoms and signs have been given in this scenario. Physical examination shows a diffusely enlarged thyroid gland. Radionuclide scan of the thyroid shows a diffuse increase in the uptake. These findings are due to which of the following reason? Now you have to answer the option. Again, read this and keep in mind this scenario and give the answer. Key has been given in this upper part, also in the lower part, and the confirmation is also over here. And what should be the answer out of these? Question over here is, these findings are due to which of the following reason? Antibodies against the TSH receptor, dietary deficiency, mutation in the rat proto-oncogene, maternal deficiency of T4, irradiation of the neck. Now, these are the two scenarios which you have to answer with your roll number. And in next lectures, we will discuss hypothyroidism and then we'll discuss one by one the scenario and the MCQs to prepare for the final exam. Thank you very much.